Well, good morning again, everyone. I hope everyone had a restful evening last night and a good breakfast this morning. We have a great panel of physicians, and it is 9 o'clock, maybe a couple minutes late. So in addition to all of you that are here today in-house, we are also live streaming this to the web. So for all of you out there listening on the web, we welcome you. Hope you get a lot of good information today. We will be having a question and answer period either after each talk or at the close of the morning, again at the close of the afternoon sessions. So those of you at home, I believe that you will have the opportunity to type your questions in. So do so when you get that prompt, and we'll see that your questions are also answered. Just going to reiterate for those of you just coming in, if you have those release forms in your notebooks, we ask that you sign those. And if you just slip those signed forms under the candy dish in the center of the table, someone from our organization will come and pick those up at that point. In your notebooks, you also have an agenda. There are no times on that agenda. It just gives the order of the presentations. So we're very flexible here. So just bear with us, and we just want you to get all the information that you can. We did not want to put a time limit on things. We rely, the coalition and all the patients from around the world really, but especially here in the United States, we rely greatly on the generosity of neurologists, researchers, and other health professionals to make our conferences informative. And this year, it is my great pleasure to introduce Dr. Kamal Shamali as our host physician. Dr. Shamali, would you like to just kind of sign and wave and whatever to our audience here and at home?
Thank you, Judy. Thank you very much for inviting us to be part of this. This is the first time we do it, and we hope for a great day. So we would like to mingle with you after the talks, and if you have any questions, please do not hesitate. We're here for you. Thank you very much.
Thank you. Dr. Shamali has pulled together a great team of experts for you guys today. I'm not used to working with notes. I usually just wing it. So these notes, folks, are for you at home. So I don't forget to say something that you might not be aware of. Our first speaker is Dr. Karen Thomas. Dr. Thomas, if you'd just like to stand up here for a second. Full biographical information on Dr. Thomas, Dr. Shamali, and the whole team are found in your notebooks. But just very briefly, Dr. Thomas received her bachelor's degree, magna cum laude, and went on to earn her medical degree at Ohio University College of Osteopathic Medicine in Athens, Ohio. I'm from Ohio, so good school. OH, go. Yes. She is a movement disorder specialist and is currently director of the Parkinsons Disease and Movement Disorders at Centera Neurology Specialist. She's also an associate professor of clinical neurology at Eastern Virginia Medical School. She's certified by the American Board of Psychiatry and Neurology. Those are only a couple of the things, a couple of accomplishments. Want the full thing? Look in your notebooks, please. Dr. Shamali and Kevin McNeely are working together to give our second presentation this morning. Dr. Shamali earned his medical degree from the Lebanese University Faculty of Medical Sciences after attending medical school at the Facultés Universitaires Notre Dame de la Paix at Namur, Belgium. Try to say that early in the morning, folks. He's had internships at the University Hospitals of Cleveland, Ohio, and Case Western Reserve in Ohio. Fellowship trainings in clinical neurophysiology, electromyography, and neuromuscular diseases at the Cleveland Clinic. So we also, again, a full information can be found in your programs. And is Kevin McNeely here? He will be joining Dr. Shamali during that second talk, and he is an autonomic lab coordinator with the Centero Neuromuscular and Autonomic Center. And his talk should be very interesting. Almost all of you who are patients either have undergone some testing or will be undergoing various testing. So we hope when you leave here that you will have a better understanding of what those tests mean when they are conducted. So I think that just about does kind of my introductions here. So I am going to turn the microphone over to Dr. Thomas, and we'll just all be very much intrigued to learn the latest. Thank you, Dr. Thomas.
Am I correct in that most folks here today are patients or family members or caregivers of patients? Is that right? Yes. Okay. I'm going to talk really just about MSA in general, sort of an overview. So I suspect that a lot of what I say, or maybe all of it, you folks already know because you've done some research and you live it every day. Okay, but I think sometimes it's nice just to pull it all together and give an overview, and then I'm going to, when I'm finished with my talk, entertain questions from you because I actually have to scoot out a little bit early today, and so will not be here over the noon hour. So I want to start with what I hear in clinic all the time when I talk about Parkinsonian syndromes, Parkinson's disease, multiple systems atrophy, and various other Parkinsonian conditions. Usually when I explain to somebody, well, you've got Parkinsonism, and I think this may represent, based on what I see, something called MSA or multiple systems atrophy. And then I talk a little bit more about Parkinson's syndromes and things like that. And by that time, I'm generally met with a blank stare and the question of, no, wait a minute, let's go back. So do I have Parkinson's disease or not? Okay. So that's a little bit of what I'm going to review here today is, what are all those letters and terms that you hear thrown around, and what exactly are we dealing with? The way I look at it when we talk about the Parkinsonian syndromes, and in particular the relationship to multiple systems atrophy, is I see three diseases that are quite related to each other but a little different from each other. And that includes typical Parkinson's disease, multiple systems atrophy, and something called primary autonomic failure. So just as some points of history, as far back as around 1900, the condition that was then known and known all the way up until really the 80s and 90s as OPCA or olivopontocerebellar atrophy was first coined by a couple of neurologists who were doing a lot of research and had seen a lot of patients in that area. By 1925, there was a recognition that the autonomic nervous system function could fail, and so autonomic failure became recognized by a couple of folks, Dr. Bradbury and Eggleston. And now we're going to fast forward to the 1960s when the term Shy-Drager syndrome was coined. To represent a condition specifically whose hallmark was autonomic failure. In the late 1960s, the idea that maybe some of these conditions they were seeing that were thought to be separate conditions were in fact the same condition, and so the idea was starting to be formed that we could group them all together and call them the multiple systems atrophies. In 1989, some of the pathology started to get more clearly recognized, such as the glial cell inclusions, and I'll talk a little bit more about that in a minute. And then it wasn't until the 1990s that the recognition of the protein alpha-synuclein was really coming to the forefront as playing an important role in not only multiple system atrophy, but certainly Parkinson's disease as well. In the 90s, there was the first consensus written regarding the classification of MSA, and then in the 2000s that was revamped a little bit. So when we look at the nervous system, we have, if I can get my little pointer here to work, there we go. So in general, the nervous system consists of the brain and the spinal cord and all the nerves that go off of it. Within the brain, there are a lot of connecting fibers, supportive cells, and then the nerve cells themselves. We divide the nervous system into the central nervous system that has to do with most global functioning, and then there's also what's called the autonomic nervous system, and I'm not going to dwell on this because I think Dr. Shamali and Kevin will probably talk a little bit about it. But the autonomic nervous system is the part of our nervous system that controls the things we don't really think about. Things like urinary function and bowel function and our blood pressure and heart rate and breathing and things like that. That's called the autonomic nervous system. It's sort of an automatic control of automatic functions. So when we talk about multiple systems atrophy, I think one of the easiest approaches in this discussion is to make a comparison of multiple systems atrophy with Parkinson's disease, because really the world in general, when we talk about Parkinsonism, the first thing that comes to mind is a picture of somebody with typical Parkinson's disease, you know, that shuffling gait, motor dysfunction, tremor in the hand, that type of thing. So I wanted to spend just one or two slides comparing and contrasting these two conditions that really are quite related to each other. So in multiple systems atrophy, we have an adult onset progressive condition, which is also the same in Parkinson's disease for the most part. However, in multiple systems atrophy, really the mean age of onset is folks in their 50s. In Parkinson's disease, the mean age of onset is a little bit later than that, okay? And I think that what you can see in the body of these paragraphs here is there is a difference. Certainly, both conditions cause what we call Parkinsonism. So do you folks know what I mean when I say Parkinsonism? Do you understand? Have you heard that term before, just Parkinsonism? Okay. So when we talk about classic Parkinson's disease, the cardinal features of that condition that were described 200 years ago by Dr. James Parkinson still exist today. We still recognize those as cardinal main features of that condition. But there are other conditions that can cause those same features, including multiple systems atrophy. So when we refer to those cardinal features, which include stiffness or rigidity, slowness of movement, balance problems, and tremor, we refer to it simply as Parkinsonism. So what that means is somebody who has Parkinsonism has some of those classic features of Parkinson's, okay? That's simply what it means. It's important to understand those terms get thrown around, and I think it gets really confusing for folks. And I think that's where that idea or that question of, well, wait a minute, are you saying I have Parkinson's disease or not? You know, that's where that comes from. But so Parkinsonism just means it shares some of those cardinal features with Parkinson's disease, okay? But what we see in multiple systems atrophy is the development of some other features as well that aren't as common in typical Parkinson's disease. And sometimes even some of the features they share show up at different times, and so it's a time frame that can often tell us the difference. So in multiple systems atrophy, certainly we have this Parkinsonism like we do in Parkinson's disease. But we can also see cerebellar dysfunction. So cerebellar dysfunction comes from an abnormality in the back part of the brain called the cerebellum, which is our coordination control center, Okay? So folks with cerebellar dysfunction will have very incoordinated movements, a lot of imbalance and incoordinated walking, incoordination of speech, and sometimes vision. So that's a little different than what we see in Parkinson's disease, okay? And of course, we see more prominent autonomic dysfunction. So I talked about the autonomic nervous system and, control of urine and blood pressure and bowel and things like that. Well, we certainly can see that in Parkinson's disease, but again, that's where the time frame comes in. Because in multiple systems atrophy, we see those things show up right at the beginning, okay? And that often can be one of the things that helps us to distinguish between the two conditions. So, as I mentioned, some of the similarities between the two conditions include that certainly they're both neurodegenerative conditions that progress. They both do affect the autonomic nervous system, but again, timing is different. They both also affect the motor system, so walking, coordination, balance, things like that. Pathologically, they both are conditions where the major abnormal protein that's at play is a protein called alpha-synuclein. Have you folks heard of alpha-synuclein before? I see some shaking heads, yeah. So we've known for a while that alpha-synuclein in an abnormal form plays a significant role in causing the disease process of Parkinson's disease and certainly of multiple systems atrophy. Believe it or not, and this is very interesting to researchers and physicians and patients and everyone that's interested in this, there are other conditions that can look almost just like this, and while alpha-synuclein may be present, it's not the major player. And so it's very interesting how some of these conditions can have different underlying mechanisms but look so much alike. This is just a couple pictures I threw in here. So at the bottom, this is what is called normal glia. Glial cells in the brain are protectant cells or helper cells to the main nerve cells, okay? So in multiple systems atrophy, it is largely the glial cells that are affected by abnormal alpha-synuclein. Okay, and that's this slide down here. This slide up here is actually showing some abnormal glial cells. Over here is a picture of normal neurons or normal nerve cells. And it is those cells that are largely affected by alpha-synuclein abnormalities in Parkinson's disease. So now you can see a little bit of difference in the underlying mechanism of the two conditions. So same protein, but affecting two different areas, causing two different diseases. And in Parkinson's disease, the hallmark problem or abnormality we see when we look under a microscope is something called a Lewy body, okay? And that's not the case in multiple systems atrophy. So some of the differences that I just mentioned, alpha-synuclein inclusion bodies, meaning that abnormal protein kind of clumps up and it gets formed into like a little encased, sorry, just had a I just had a TIA. It forms, it gets surrounded by, for lack of a better term, membrane, let's say. That's not accurate, but, and it forms a little, what we call a body or an inclusion. So these little inclusion bodies in Parkinson's disease, we call them Lewy bodies. And they look a little different than the inclusion bodies we see in multiple systems atrophy, and they're located in two different areas. That's basically the information I'm trying to give you. Again, the autonomic dysfunction can occur in both, but in multiple systems atrophy, that tends to be one of the presenting features. So very early on, one of the first things that happens is autonomic dysfunction. Multiple systems atrophy tends to have earlier speech and swallowing abnormalities seen. And I will say this is a big thing for me clinically. Often I'll have somebody come into the office and they clearly have Parkinsonian or Parkinsonism features. And I will think, well, this may be Parkinson's disease, but you know what? Their speech is somewhat odd in its pattern for Parkinson's. And it puts up that red flag for me that maybe what we're dealing with is not Parkinson's disease, but multiple systems atrophy. And I actually see that fairly often. Parkinson's disease symptoms tend to respond better to medication than multiple system atrophy. And in particularly, what I'm talking about is the medication used to help with mobility, like levodopa or Sinemet is a name for it. Have you folks heard of that medicine? Okay. Well, in Parkinson's disease, typically when we give that medicine, there's almost a aha feeling when they take it. When a person with Parkinson's takes it, with relief of stiffness and sometimes tremor, slowness of movement. Whereas in multiple systems atrophy, in folks that have those same symptoms, they may not get that robust aha feeling from the medicine. And unfortunately, some folks don't get any benefit from that medicine. And multiple systems atrophy is a condition that tends to progress a little bit more aggressively or quickly than regular Parkinson's disease does. Additionally, in multiple systems atrophy, often we will see early or more predominant facial movements, abnormal movements of the face, what we call dyskinesias. Have you folks heard of the word dyskinesia before? Okay. So, the easiest way I find to describe what dyskinesia is you think of Michael J. Fox, who has Parkinson's disease, and he has dyskinesias associated with Parkinson's disease. So very often when you see him on television or something, his face may be moving in some abnormal way, or you may see him kind of wiggling with his arms or his body, and that's dyskinesia. In multiple systems atrophy, we tend to see a little bit more of the dyskinesia early on and involving more of the face and facial expression and mouth. In some patients, we also will see a more prominent abnormal flexion of the head or even of the trunk that may indicate we're dealing with multiple systems atrophy versus regular Parkinson's disease. And again, keep in mind with some of these things, it's not that we can't see it in Parkinson's disease, it's just a matter of it may be more prominent or occur earlier in multiple systems atrophy. And multiple systems atrophy has been associated with noisy breathing, what we call stridor, where it sounds almost like somebody's struggling to breathe, and that can be seen fairly often, although probably not quite as often as some of these other things. So this is just a picture of some abnormal truncal posturing that's more likely to be seen early in multiple systems atrophy than in typical Parkinson's, although again we can see it in both. This kind of leaning syndrome that's actually called Pisa syndrome, based on the Leaning Tower of Pisa. And then this is the abnormal forward bent postures that I talked about when it is involving the whole trunk. Like in this picture, we refer to that as camptocormia, okay? But we often will see, more so than this, we'll see this head posturing where the chin is actually resting down on the chest. And while the person, at least early on, can lift their head up, it's very difficult to keep it there. In fact, as soon as they stop thinking about holding their head up, their head will drop back down again. So let's talk about the classification of multiple systems atrophy. So for many years, we actually considered there to be three three types of multiple systems atrophy, but more recently, from what I could read, really the classification has been reduced to considering just two. But I'm going to talk about how I've always considered it, and I still tend to talk about it as three types to my patients. One type that we traditionally referred to as multiple systems atrophy type A was the type where really the most predominant feature was what we refer to as dysautonomia or autonomic dysfunction. And that's the type where there may be very minimal Parkinsonian symptoms or Parkinsonism. There isn't as much imbalance or incoordination. Really, the big feature is involving the autonomic nervous system. So problems with drops in blood pressure, what we refer to as orthostatic hypotension, early problems with a lot of bladder dysfunction, frequency incontinence or urinary retention, constipation, things like that. That's really the predominant feature. I think and Dr. Chamali might be able to answer this better, but I think the reason it was reclassified is technically by definition, all multiple system atrophy types have that dysautonomia, and so that primary type A was sort of put by the wayside with the assumption that the other types will have that as well. And then the one I see most often is MSA type P, and that P stands for Parkinsonian features. And in fact, these are the folks that they come in the office, and we most often will diagnose them as Parkinson's disease, okay? But with time, things start to happen, and we recognize that, you know what? I think we're going down a different pathway here. This doesn't seem like typical Parkinson's disease. And sure enough, within a short period of time, it's pretty obvious that this person has multiple systems atrophy type P. Some of the hints that I've already mentioned are that change in speech that occurs early on. That's a big hint for me. Also, although it's not 100%, folks with this type of MSA, they're Parkinsonian features, so the rigidity, the slowness of movement is a little more symmetrical than we see in typical Parkinson's disease. Parkinson's disease itself tends to be very asymmetrical. One side is definitely worse than the other. This type used to be known as striatal nigral degeneration, but now is just referred to as MSA type P. And then the other type that is less common, but we do see, is MSA type C, and that C stands for cerebellar dysfunction predominance. And these are the folks that really have much more of a problem with coordination, truncal coordination, walking coordination, upper extremity coordination, speech coordination. And they also may have some other things that we see on exam. This is the MSA that used to be referred to as olivopontocerebellar atrophy. So I think really on this slide it's nice to know that there are different types of MSA, but the truth is, to those of us making the diagnosis and following folks, often for many visits, everybody has the same features. It's really, again, time that tells us, okay? So features of multiple systems atrophy include that autonomic dysfunction that I talked about. One of the toughest ones to deal with is something we refer to as orthostatic hypotension, or drops in blood pressure that occur when you change positions. I'm not going to dwell too much on this because Kevin and Dr. Chamali are going to talk more of this. Urogenital dysfunction is very, very common and one of the early features. And that, as I've already mentioned, includes urinary overactivity, urinary incontinence, urinary retention, so dysfunction of the nervous system input to the bladder. Erectile dysfunction or sexual dysfunction is very common as well. That is also controlled by the autonomic nervous system. And then Parkinsonism, as I mentioned, and these are the cardinal features of Parkinson's disease: slow movements, some rigidity, tremor, and postural instability, okay? This postural instability is one that in Parkinson's disease, even though it's a cardinal feature, it doesn't typically show up early. It's something that shows up many years down the road. However, in multiple systems atrophy, we may see it right at the beginning, or certainly within 3 years of onset of other symptoms. And that, again, is another red flag that we're probably dealing with multiple systems atrophy and not Parkinson's disease. And then, as I've already mentioned, that cerebellar dysfunction, where we have incoordination of significance of gait and upper extremities, and even involving speech and sometimes eye movements. So these are some of the criteria we use for giving a diagnosis of multiple systems atrophy. We certainly think of possible multiple systems atrophy if somebody shows up with Parkinsonian or cerebellar symptoms and they have autonomic dysfunction or urogenital dysfunction, and they have one of other supporting features, okay? And then probable multiple systems atrophy includes all of that, plus their Parkinsonism, when you try to treat it, doesn't respond very well to the Parkinson's medicine, like I mentioned before, okay? The diagnosis of definite multiple systems atrophy, just like the diagnosis of definite Parkinson's disease, is only confirmed through pathologic studies, meaning somebody has to slice the brain up a little bit and put it under a microscope and look at it, okay? I tend to not recommend going to this degree in trying to get a diagnosis. It makes follow-up not very easy. The diagnosis is really made largely by clinical features and by what you tell me. What is your story? What is your history of these conditions? That is key. That is key. I probably spend more time getting a history than I do doing an exam, because history is everything in these conditions. There is an imaging study out there that is FDA approved that can be done. It's a nuclear medicine scan or a SPECT scan that can tell us whether or not we're dealing with a condition of dopamine deficiency in the area of the brain that is affected by these conditions. But that's all it tells us. It does not answer the question, is this MSA or Parkinson's or one of the other Parkinsonian syndromes that cause dopamine dysfunction, okay? But a lot of folks want to know, is there an X-ray out there or a test that can be done? Yes, to some degree, okay? And certainly, in some patients, there can be changes seen just on a plain MRI scan. But that is not 100% across the board. It helps if it's there, but if it's not, it doesn't really exclude the diagnosis. This is a picture of that SPECT scan that I talked about. And what we have here in this slide is it's called a DAT scan, by the way, which stands for dopamine transporter. The picture, as you're looking at it on your left, is of a normal scan. You see the bright area in the center is the area of the brain that's called the striatum, where dopamine transport and dopamine uptake occur. And this is the area that can be affected, or that is affected in the Parkinsonian syndromes. So what you see here is this nice, even, symmetrical, bright area. And then this is a picture through that same area of the brain of somebody with a dopamine deficiency disorder, okay? So this may be Parkinson's disease. It may be multiple systems atrophy. It may even be some of the other Parkinsonian syndromes. This is a plain MRI film of somebody with multiple systems atrophy. And again, this does not show up in every MRI of every patient taken. But what we see here is in this area that's called the brainstem, and this is actually the pons of the brainstem. You can see a little highlighted cross-like image there, where the big arrow is, okay? We call that, I don't know what it is about radiologists, they name everything after food. They do. This is called the hot cross bun sign. So let's move on to treatment of MSA. So how do we treat it? Well, unfortunately, I don't have that pill that cures it. I think there's a lot of us waiting in line anxiously for that to happen, and oh, that would be just wonderful. And in fact, we don't really have anything that modifies the disease. What I mean is we don't have anything out there that slows that process down. It sets itself on a pathway, and we can't really interrupt that, okay? So what that means is the medicines that we do have available to treat MSA are treating your symptoms, okay? They're to help with the symptoms. There are also, and we can never forget this, there are also in these conditions many non-drug treatment approaches that should be incorporated along with drug treatment, okay? That's extremely important. I like this slide. So, obviously, urinary dysfunction occurs in MSA, and but I might attest to the fact that it occurs even when you don't have MSA. And often we find ourselves waiting anxiously in line for the next stall to open up, right? So medication treatment. For the dysautonomia, that includes dysfunction of sweating, that low blood pressure, things like that. There are some medications that may be beneficial. Sweating is a little bit harder to treat, and you know what, I'm going to leave that for Kevin and Dr. Shamali to address. Low blood pressure, there are a few drugs on the market that can help support your blood pressure to keep it from dropping, and they have a couple different mechanisms. The one that's been around the longest is a steroid called fludrocortisone. Have any of you ever been on that or heard of that? Okay. So that can help to raise your blood pressure by increasing volume. Midodrine has been out for a while as well. That works by constricting blood vessels and helping to raise your blood pressure to keep it from bottoming out when you stand up. Pyristigmine is a drug that's used in another neurologic condition called myasthenia gravis, and there are some reports that it may be beneficial in folks that have this orthostatic hypotension problem. Caffeine, you know, I got to tell you, I'm a big fan of caffeine. Not only personally, but there is more and more evidence out there that caffeine can be beneficial for several issues in Parkinsonian syndromes and in Parkinson's disease itself. But certainly it can also help, through being a stimulant, help in supporting blood pressure. And then the newest drug to the market is one called droxidopa, or Northera, I believe is the brand name. That was just approved by the FDA, and that works as a prodrug to adrenaline or norepinephrine in helping to raise blood pressure, okay? And it has been found through many clinical trials now to be quite effective in doing such. And again, I think it's important, I'll talk about this in a couple slides, that you remember there are always non-drug things you can do as well that need to go along with these drugs. I hate to say this, but the truth is all of these drugs we use are okay for what they're trying to accomplish, but these are definitely conditions where you cannot expect to just take a pill and be better, okay? I tell all my Parkinson's patients and Parkinsonian patients, you know, having these conditions is like having a full-time job, It really is. And you have to dedicate a lot of time to working at feeling better and having a good quality of life. So urogenital dysfunction, certainly with urinary urgency and frequency, that got to go right now feeling. We use the same drugs that anybody with the got to go right now problem uses to try to calm down that bladder muscle overactivity. And then erectile dysfunction, no mystery there either. We use the same medicines, although in multiple systems atrophy we have to be very careful. And some folks may not be able to use this because of that blood pressure problem, okay? Because it can alter your blood pressure. Sleep problems, insomnia, and various sleep disturbances are very common in multiple systems atrophy and all of the Parkinsonian syndromes, really. Active dreaming is common in these conditions. The drugs that are in the class of benzodiazepines are used. Those are Valium-like drugs, so clonazepam is one of the most commonly used. Sleep apnea is very common in this condition, and that's treated through a sleep specialist who provides the machine to help keep the airway open at night when you're falling asleep. Very important to treat, by the way, because untreated sleep apnea can cause all kinds of problems during the day, in addition to putting you at greater risk of things like cardiovascular disease and stroke, okay? So I can't emphasize that enough. If you think you've got sleep apnea, or your partner says, geez, you really snore badly, or you sound like you gasp for air, those are all signs of sleep apnea. Or for you yourself, waking up feeling like you're more tired than when you went to bed, that's a hint that you may be dealing with not getting enough air at night, okay? So really important to treat that. Mood disturbances in MSA and all of these conditions likewise are very common. Depression, treated with antidepressants like the serotonin reuptake inhibitors. My favorite to use in multiple systems atrophy is actually one called paroxetine or Paxil, because there are some studies that show that for whatever reason, paroxetine above the other drugs in that class seems to also help more with drops in blood pressure, okay? And then some folks do have some anxiety, and again, we use some of the anti-anxiety medicines if needed. We have to be very careful. Those are habit-forming drugs. They can make you groggy, and if you've got some balance or mobility problems, they can actually make that worse. So when we're treating Parkinsonism, I've already mentioned levodopa. Levodopa is the main ingredient in a drug called Sinemet. It is also in several other brand name drugs, okay? Levodopa has been around for a long time, and it's the only medicine that directly replaces dopamine in the brain. There are other medicines out there that are used to treat the symptoms of Parkinsonism, such as the dopamine agonists. However, those drugs are notorious for dropping blood pressure. So we have to be very careful about that. And in fact, if I think somebody has MSA, or certainly if they've got blood pressure instability, I don't use these drugs. Amantadine may be a medicine to help with some of those oral facial movements, that dyskinesia that we talked about. We know in regular Parkinson's disease, folks that get dyskinesia can be benefited by amantadine. Amantadine's been around for about 50 years or more now. Was actually developed as a medicine to treat the flu, but was found to help with Parkinson's symptoms. And in folks with some types of multiple systems atrophy or other Parkinsonian syndrome, muscle rigidity may be a problem. And occasionally, when it's very bothersome, adding on a little muscle relaxer might be beneficial. Again, like some of those other medicines, we have to be very careful with them. They can make you groggy and imbalanced. So those are the drugs we use, okay? Again, I can't emphasize enough, any medicine that's used for this stuff has to go along with non-medication approaches to treating it as well. So when we look at treating low blood pressure or orthostatic hypotension, There are a lot of things you can do to try to help reduce the risk of that occurring. And that includes the things that I have listed here. You guys? Okay. I didn't want to make it repetitive. Certainly, all of these things have been found to, in some folks, actually significantly improve the orthostatic hypotension. Just generally increasing your volume, your fluid volume in your body by increasing your fluid intake. And then we know that when you get up in the morning, you're somewhat fluid depleted. So the very first thing you should do is replenish that with drinking a 16-ounce glass of water. Okay? And if you're like most of my patients, you're groaning because you don't even drink 16 ounces in an entire day. But this is really important. Increasing salt intake can also help expand that volume to support your blood pressure. Compression stockings. How many people in here wear compression stockings? Just a couple. Okay. So either we have a room full of people that don't have problems with drops in blood pressure, or just a few people are willing to wear them. These actually can improve orthostatic hypotension fairly significantly. So I encourage you to talk to your doctor about it if you have this problem. The way we eat can make a difference in your blood pressure stability as well. You know, we're a 3 big meal a day society, but the truth is that's probably not the healthiest way to eat. And certainly if you have problems with drops in blood pressure, it's definitely not a good idea. If you eat a big meal, your gastrointestinal tract will take blood away from the rest of your body to try to digest that meal, and what will happen is you're more likely then to have drops in blood pressure. So I recommend becoming a frequent snacker or a grazer where you're kind of eating all day long in a smooth fashion. Being mindful of nutrition, of course. Elevating the head of your bed at night when you sleep. So always having your head above the level of your heart can be beneficial in reducing, especially when you first get out of bed, that drop in blood pressure that can occur. I must think compression stockings are important because I have them on there twice. So, and exercise. So many people feel that because they get a little lightheaded when they get up and their blood pressure drops, that means they shouldn't get up. They should be sitting. Well, the longer you sit, the harder it is for your autonomic nervous system to adjust when you finally do decide to stand. And you actually end up worsening your orthostasis or your orthostatic hypotension. So staying active, being up, moving around is actually extremely important. Urinary dysfunction. The non-medication treatments include just sort of timing when you go to the bathroom. Maybe every hour or every 90 minutes you just get up and go, whether you feel like you have to or not, because I guarantee you, when you get into the bathroom, you'll go. Okay? It's somewhat of a conditioned response. But, and that way you can avoid waiting too long and then can't quite make it. Protective garments, of course, to help with that. I want you to drink lots of fluids, but maybe cut back on them a little bit in the evening so you're not up all night going to the restroom. Non-medication sleep problems can be addressed with what we call good sleep hygiene. And that is making sure you're in a room that's comfortable, that it's dark enough, that it's cool enough. Most sleep experts recommend you go to bed every night at the same time so that your body gets into that routine. Our sleep is controlled by cycles, so try to keep routine in the cycles. And no vigorous or exciting activities just shortly before bed, because that will keep you up all night. Gait abnormality and postural instability. Like I said before, some folks don't get relief from medicines in their mobility to any degree. Even in Parkinson's disease, though, when we talk about postural instability or balance problems, the tendency to lose your balance and fall and not be able to catch yourself, those symptoms do not respond to any medicine at all. It doesn't matter if we're talking MSA or Parkinson's disease or any of the other Parkinsonian syndrome. That is where physical therapy plays a huge, huge role, okay? And there has been, over the last 20 years, the development of a program called LSVT Big Therapy. LSVT stands for Lee Silverman Voice Technique, okay? That was voice therapy created specifically for Parkinson's disease patients, but has been expanded to other Parkinsonian syndrome. And then an offshoot of that is a physical therapy program for mobility in the Parkinsonian syndromes, and that's called the BIG program. And that actually has been found to be very beneficial, especially in the folks that have the smaller movements, more of a shuffling gait, some limitation to amplitude of movement, because that's the focus of that program, is to increase amplitude, increase stride length, make everything you do in an exaggerated fashion to help with that. The only folks with MSA that probably would not do well in the big program would be the folks with MSA type C, where their movements are not restricted, they're somewhat chaotic and uncoordinated instead. However, physical therapists, neurotherapists have ways to approach that as well to help you control your movements better. And then, I recommend massage therapy very often for my patients that have a lot of rigidity. And then there are other modalities like music therapy, especially in gait disturbance and rhythm of movement problems that can be very beneficial. Did I cover everything here? Oh, and then there have been several studies on Tai Chi in the Parkinsonian syndromes. And Tai Chi has been found to strengthen the core and make your center of gravity stay where it belongs a little bit better. And so the studies have shown that, in fact, people that go through Tai Chi tend to reduce their risk of falls, which we all worry about in these conditions, of course. These are just brochures from the LSVT. They actually have a website called lsvtglobal.com if you want to get on there and check it out a little bit. The therapists who do these types of therapy have to be certified by the LSVT Global organization. When we talk about the speech problems can be significantly frustrating in folks and family members because, especially in multiple systems atrophy, speech can be so impaired that communication becomes very difficult or almost impossible. So certainly, even at the slightest hint of a speech problem, getting into a speech therapist to work with them using some of the LSV techniques becomes very important. They need to work on articulation because, especially in MSA, articulation is significantly impaired. And then if the impairment is such that it makes communication nearly impossible, there are other devices that can help you stay in communication with the folks around you. Things like word boards. There are computer-based programs. I think you can actually put a program on an iPad that will interpret for you, will have phrases that you use, and you just press the button and it will say the phrase. And that's kind of the same concept behind this thing called the Dynavox, where you press a picture and it says hello for you, or how are you today, things like that. But it can help you stay in communication with those around you, and that's very important. Swallowing problems can be significant with advancing MSA. It's important that that's followed closely right from the beginning. And I will tell you this, it's also important that when your physician tells you, maybe we should check a swallowing study, that you not be resistant to that just because you feel like you're not having swallowing problems. Because a significant portion of folks with this condition will actually be what we call silent aspirators. And what we mean by that is they feel like they're swallowing fine. They don't feel like they're having any problem. But a swallowing study will in fact show that some of the things you're swallowing will be going down the wrong way and getting into the airways. Okay? So that's very important to understand that. I hear that day after day after day where I will say, I want to get a swallowing and say, no, I'm not having any problems. When swallowing problems are obvious to the patient and those around, it is very important to get in to see a speech therapist who deals with swallowing, and they can often recommend just simply a change in diet and the way your technique of eating and swallowing is to improve the chances of things going down where they belong. Unfortunately, in these conditions, sometimes swallowing gets so impaired that eating or drinking by mouth becomes extremely dangerous. In which case, then, we will often recommend that a feeding tube be placed and you gain nutrition and fluids through that. This is a picture of what's called a PEG tube or a feeding tube. Some folks are very resistant to that and do not want that. That is not for me to decide. That is only for you to decide. But I would encourage you to discuss whatever your feelings are about it with first your family members or your caregivers, and second with your physicians. Okay, it's important right from the get-go that everybody's all on the same page about what kind of care you want as the disease progresses. So, again, in summary, these non-medication therapies are as important as any pill you put in your mouth for this condition. And includes the various physical therapy techniques, the speech therapy techniques, which also encompasses swallowing therapy, occupational therapy to help with how you perform your activities of daily living, and then the others that I mentioned, things like Tai Chi and music therapy and massage therapy, art therapy. I have down here at the bottom acupuncture. I have a lot of patients that get acupuncture with varying success. Unfortunately, we don't have a lot of good studies on acupuncture in these conditions, but as I read more and more about acupuncture, I find it to be a very fascinating modality, and I think in some people it can benefit with various symptoms, and it is not invasive and not harmful, and it can only, the goal of acupuncture is to normalize things, so you can't get overdosed on acupuncture either. Just like you can't really get overdosed on massage therapy or music therapy. So I really encourage you all to look into these types of ancillary treatments. Research and development, where are we? Well, we certainly are gradually gaining improved understanding of the underlying mechanism of multiple systems atrophy and the other Parkinsonian syndromes. We've learned a lot in the last decade about the genetics, particularly of Parkinson's disease, and it sounds like that gets all the attention, but don't be dismayed, because I can tell you, if we can thoroughly understand Parkinson's disease, which again is an alpha-synuclein disease, okay? If we can thoroughly understand that disease and find a cure, there is a great chance that will absolutely benefit people with multiple systems atrophy as well, because they're so closely related. There is certainly a need for focusing right on that pathologic mechanism, or that abnormal alpha-synuclein, and I can tell you that worldwide there are probably at least 4 or 5 different compounds being developed to directly work on abnormal alpha-synuclein with some promising early results, okay? And then we always need improvement over the medicines we have right now to treat the symptoms. And fortunately, we just had the development of the droxidopa or Northera that I talked about, but we need better therapies in all aspects of symptomatic treatment. So, and I have one slide on pure autonomic failure. It's very similar to multiple systems atrophy. It's known as Bradbury-Eggleston syndrome, or used to be known as that. It is marked by significant dysfunction of the autonomic nervous system, as the name would imply. However, it doesn't have other involvement of other parts of the nervous system like MSA and Parkinson's do. It typically affects those in their mid-50s or beyond, and it tends to be a much less aggressive condition, okay? So most folks with pure autonomic failure will have a normal life expectancy and live with the inconvenience, I guess, to some degree, of the symptoms that it causes. It is a little different in that its drops in blood pressure, orthostatic hypotension, are often associated with too high of blood pressure when the person lies down, which we can see, especially with the medicines, in some of these other conditions, but that tends to be one of the features of pure autonomic failure. It's also associated with neck heaviness or pain when standing. That's relieved with lying down. Again, that actually is because of the drop in blood pressure that is occurring. Treatment's not any different, really, than any of the other things we talked about. Again, these are symptomatic treatments. I put this in there because we're close to Halloween.
Dr. Thomas,
longer than I
thank
thought
you
I was
so very, very much.